good to be doing this workshop with you. Hi, everyone. Sorry, I was on mute there, which is such a schoolgirl error, considering that I've been speaking at conferences for so many years now. But lovely to be back again. And for those of you who were at that first session that I did, this session is the sort of more in-depth focus on what I'd just started to touch on earlier. So this is the focus. Okay, I'm going to talk through some of the key changes in good medical practice, but really, really explore those anti-discrimination themes in more detail. And I'm going to be using case scenarios with you as well. There are a couple of videos, which, all things being equal, the sound will hopefully work. But if there are any challenges, then they're only short clips, so we can work around that. But it is interactive in other ways because I am using Mentimeter. So just to test that, if I could ask you to grab your mobiles and log on, well, go on to menti.com, just type in menti.com, and you'll get a screen that allows you to enter that code that is there at the top of the slide. And I just tested it all during the break, so all things being equal, it will work. My, yeah, it's coming up for me. So I'll just give you a few moments to get on. You can do it in another browser screen if that is easier for you. There we go. We have some people logged on. Brilliant. I always put in the define read. It's yeah, I have to say there are many, many documents that I just have a scan of rather than a full thorough read. Okay. Right. Now, we've got some more responses coming in. We haven't got any yeses yet. But that's fine. Okay, brilliant. Thank you. I am pleased to see that some people have scanned it. But what I'm going to do is just highlight the key themes for you. Okay. So there are a number of domains. I'll take you through those in a few moments, but these can all be put into these 5 key themes. And as you will see, of course, we still have duties around patient care, so promoting patient-centered care and that continuity of care and delegation, all of that. So things that you will be familiar with as healthcare professionals and aspiring healthcare professionals around what we were talking about before, confidentiality and shared decision-making are certainly there, and they haven't changed. Not a great deal anyway. As I said earlier, there are anti-bias themes peppered throughout, but the crux of those duties haven't changed. However, there are 3 themes here that you can see are all about that culture and anti-discrimination piece. And these duties are either brand new, representing that seismic shift, or they are much more robust and explicit than they previously were. So with all that in mind, my next question for you, given that those duties are so much more explicit, what do you think? So that's quite interesting. So far, everyone is going for yes. I asked this question to a group of responsible officers not too well. I've been doing a series of events for them. And it was quite interesting, given their role of accountability in the organisation. So it was quite a mix of responses. We've got one person saying no. Well, The brave individual not following the group there is correct. It doesn't change the thresholds. And that is because I like to see, the way that I like to think of it, the standards are over here, fitness to practice is over here. So the standards describe good practice. It is what a good doctor looks like, recognizing that we are all human and will, of course, make mistakes. Yeah. So therefore, a departure from good medical practice is not synonymous with fitness to practice necessarily. It depends on so many factors, other factors. So it depends on the gravity. It depends on the context. So what were the workloads like? What had that person been through that day? Is that person going to continue to practice? Are they just about to retire, for example? It also depends on the remediation and insight. Could it be that there is an area of practice that this person really, really struggles with, but they've got great insight on that and they're remediating their practice? So it depends on all of these factors, and therefore good medical practice, try and view that as it is a document around medical ethics. It's what that good doctor, and it will apply to physician and anaesthesia associates too, what's there in regulation. That's what it's for. It is not a set of edicts from up on high. It is not a rule book by any stretch. Okay. You can exercise your professional judgment around those duties because, again, that professional judgment is going to depend on everything in front of you. Okay. So with that in mind, let's have a look at the 4 domains. Now, the domains of knowledge, skills, and development, going anti-clockwise, which is slightly counterintuitive, but knowledge, skills, and development, patience, partnership, and communication, and trust and professionalism. Those 3 domains are where there's been attenuation, some slight changes, but no real revolution, if you will. So, for example, in knowledge, skills, and development, in the previous set of standards, we've talked about reflection before. This time we talk about reflection, but we talk about considering your own biases as part of that reflection. So as I say, anti-bias is peppered throughout, but that's not a seismic shift. You'll recognise the duty if you were familiar with Good Medical Practice 2013, the previous version. We've also brought into Good Medical Practice from our decision-making and consent guidance, we have brought in some duties into Good Medical Practice. From our social media guidance, we've brought in some duties into Good Medical Practice. So no real change, we've just promoted it into that core set. And that means that it is only that new domain, colleagues, culture and safety, that's really changed. All that said, there is one thing that I do want to explore with you. And that's because it's led to a lot of conversation online. So I feel it would be remiss of me to not explore it with you. And that is, in the duties for a long time in the standards, we've talked about being courteous and respectful. With this new version, we've added a word. We've added the word kindness. So treating your patients with kindness as well as courtesy and respect, and colleagues too. And that resulted in a lot of debate, which I found really interesting. And there were some people that were really, really worried about it. Some people who were really strongly advocating for it. There was a time where we thought, okay, we might remove that word. But then there was, again, a lot of pushback to say, no, keep it in for these reasons, which I'll come to in a few moments. But I wanted to test your thinking. So with that in mind, does anything worry you about the inclusion of the word kindness? So saying you must treat patients and colleagues with kindness as well as courtesy and respect. So I'll give you a bit longer because you get to type in a response here. interesting. Yeah, so that's the main thing that we're hearing from people in terms of the worry. Yeah, that's a really, really important point, and I'll come to that, the whole gaslighting and exploitation. People misuse it, yes. So, as you might imagine, I've been in the feminist space for a while now, given my work with survivors of abuse. And yeah, that whole "be kind" hashtag, that was used against feminists well before recent debates in healthcare. Yeah. Pick holes, being walked over. That links in with what a number of people are saying, and I'll come to that. Yeah, subjective. That's like the first comment, isn't it? Okay, so thank you. I'll keep scanning this. Yeah, for not fitting in with this concept, and I think that's such an important point. So let's look at those points first around the subjectivity and not fitting in, etc. How do we measure it? Well, first point I would make. Let's go back to what I just said about what the standards are. They are not fitness to practice thresholds. They are what a good doctor looks like. And yes, this is a subjective subjective word in the sense that my kind might be very different from what your version of kind is. But equally, my version of courtesy might be quite different from what your version of courtesy is. Within ourselves, any healthcare colleague wants to demonstrate what they perceive to be kind. And bearing in mind the standards are what that good doctor looks like, and not fitness to practice, we think it is a reasonable word to understand. However, this brings me to the other concerns about not fitting in and it being weaponized, which is essentially what a lot of those comments are saying. And one thing that I'm seeing a great deal of is a conflation of kindness with niceness. Now, if we weren't talking about the regulator setting this as a duty, we want people to be kind to us. We want to be kind to our patients. Now, that does not mean that we want to be doormats, of course. And being nice, again, it's arguable, but nice when you don't mean it, nice when there isn't any compassion behind that, nice as in just putting up with things that you don't want to put it up with things is very different from being kind. You will have heard the aphorism that sometimes you need to be cruel to be kind. Now, I'm not saying that that's what the guidance is talking about, but that brings me to my next point. All the feedback that we received was really helpful in helping us decide to keep it in, but helping us to change the draft so that we added a lot more detail. And that detail makes really, really clear that being kind does not mean that you're not going to break bad news. It does not mean that you're not going to raise concerns. You're still going to be doing all of those things. Yeah. So it's how you do it that matters. And yeah, one person's view of how you do it might be different from another's, but it's what you're aiming for, yeah, that matters. So hopefully that clarifies the inclusion of the word kindness. And I'm just going to, in fact, that the person who's commented most recently, almost as if you're a plant, and I promise I won't. That brings me to my next point. If we do not include kind behaviours by seniors, juniors will not role model these. Now, there's another element to that I wanted to speak about. And when we were consulting, one of the stories that we heard was from a group of trainees who were really passionate about including the word kindness. And that is because they had been subject to really unkind behaviours. Most shockingly, locked in a room, kid you not, locked in a room until they agreed to cover rota gaps. I mean, unkind doesn't even begin to cover it, you know. So this is bearing in mind that good medical practice is about driving culture change. We want kindness in the culture, but at the same time, by way of reassurance, it's not a fitness to practice threshold. It's a lever for that positive change. So thank you for all your comments, really, really helpful. But I hope that demonstrates that all of those domains, there's been attenuation that is evolution rather than revolution, to use that slightly trite phrase. And it's all about driving cultural change. But where we've got that seismic shift in driving cultural change is here in colleagues, culture and safety. And that is where we talk about being kind, as well as courteous and respectful to your colleagues. And again, that doesn't mean you're not going to raise concerns about them. These are kind of in the teal boxes. Those are the themes within these this domain. And it's predominantly paragraphs 48 to 59, but also, for example, 63 and 64 talk about induction and support, especially for international colleagues, for example. So this whole area is very much about that significant shift. And I'm usually allergic to too much text on slides, but I do want to showcase some of those changes. So this next slide, I've excerpted elements from the intro to the domain, but also excerpted little bits of some of those duties. So as I say, 48, treating colleagues with that kindness, courtesy and respect because we deserve it. We're all human. We're not going to be perfect all the time. But as I say, the standards recognise that. But this is what we should be doing. And that brings me to Anika's story. Anika, who was not treated with kindness. So the scenario, you bump into Anika. Anika is a new colleague, internationally qualified, and she is she's just started as a nurse, and she is reprimanded. She tells you, when you ask her why she's upset, she tells you that she's been reprimanded for staying late, whereas a male colleague was praised as conscientious for doing exactly the same thing. And it got her a little upset, and you try and explore it with her, and she just says, oh, I'm probably just overthinking it. It was just now, and I was a little bit upset. You probe a little bit more. And Anika tells you that actually she'd had a difficult day all round, and earlier on in the day, bearing in mind that she's really pretty new, a couple of weeks maybe into the organisation, a senior nurse colleague said to her, why are you just standing round? And she said, oh, I was just waiting for instruction. I was always told to wait for my senior to tell me what to get involved in. And the nurse colleague gets quite cross and says, that is not how we learn things around here, and kind of huffed off. Okay. So this has clearly shaken her a bit as well. And you've always thought, albeit it's just been a few weeks, you've always thought of Anika as quite quiet and not getting involved in things. But as you start to converse more with her, albeit she's still trying to dismiss things, you realise that she's feeling left out. She's not invited to group socials. And then finally, as he's sitting down for a coffee, she reveals more to you, and she put in for leave before she started, when contracts were all signed and all of that. And she's just been told that her leave, albeit that it's 2 months away, is not going to be granted. And that's her sister's wedding in Kenya that she's now not going to be able to go to. And Anika's story, of course, I've made her up, but I've made her up based off many of the trainees, locally employed doctors, nurse colleagues that we hear from. And what she is being subject to here, unkindness, but also unwritten rules and very possibly discrimination. And there's been work on unwritten rules in the system for years, absolutely years. Okay. So from nearly 25 years ago, this work was looking at cultures in terms of governance. And clinical governance lead said this: there are microcultures, every single different practice, but then also ward rounds. Every ward round might have its own new dynamic culture, the wider hospital trusts that you might work in, the department, etc. And they all have their unwritten rules. These are around governance, but Anika doesn't know what the unwritten rules are. No one's bothered to tell her. No one's given her a good start. And she's an outsider. They've made her an outsider by not welcoming her in. Unwritten rules as well can be really, really powerful. And this next slide is from the same research here from Cullen, Nichols and Halligan. And I thought it was an apocryphal story, but it was in the research, so it's good enough for me. So I'll shut up and let you read that. I've injected it I've inserted it to inject a bit of levity, but it's interesting. And we have seen, many of us, I think, these scenarios where, the senior says that, so let's just do it, even if it is ridiculous, or the senior is modeling unkind behavior, so we don't feel that we can be kind, or the senior is being bullying, don't feel that we can be active bystanders. So, unwritten rules affect us all. And I'm just going to skip this slide because I want to get to a couple of more scenarios. And and if you've got any thoughts on that, then of course you've got the chat available too. But what I want to get to is how we overcome these unwritten rules and the very negative impact these unwritten rules, which are essentially the culture, have. And that is that they have a disproportionate impact on some colleagues in particular. And as you might imagine, those colleagues are ethnic minoritized colleagues, internationally qualified colleagues, and women. And what this model here is from work that's been done for a long time now. This is from 2014 on differential attainment. So this is where colleagues, particularly from minoritized ethnic groups, different faith groups, etc., don't have the same positive outcomes as, let's say, a white male colleague. Okay, they would be represented in the low risk area, where they have the best outcome, whereas women, minoritized ethnic, and some faith-based groups are subject to vulnerability processes, have a poorer outcome. And what we need to do is put in those protective processes to ensure they have a better outcome. Now, Earlier this morning, I talked about protective factors when I shared that screenshot of the sexual harassment video. And this is what we want people to do, as I said, put in those protective factors, which was also on that circle slide. We know the evidence base shows, just as I said, our IMGs, international colleagues, minoritised ethnic and women, are subject to risks and vulnerabilities. And these are what some of those are. As I say, there's really strong academically robust evidence around this. And there are all kinds of things like cultural communication. So I'm doing some work. One of the portfolios I lead at the GMC is for international colleagues. And I'm doing some work on cross-cultural communication. I'm also going to Japan very soon. And as part of that work, I was looking at, just out of interest, Japanese culture. And I was comparing that to Dutch culture. And professionally speaking, if something goes wrong, let's say in Japan at work, then it is normal to provide a lot of context, a lot of explanation. It's also normal in Indian culture, in Nigerian culture. In Dutch culture, it's not normal to give all of that context. It's much more normal to be direct and give you the headlines. So let's say a doctor who trained in the Netherlands is speaking to a doctor who trained in Nigeria and asking them what went wrong. And the Nigerian doctor is giving them all this context. The Dutch senior doctor might be sat there thinking, they're making excuses. They're giving me far too much information. Why aren't they being straightforward? Similarly, if it was the other way around, the Nigerian doctor might be thinking, they're not giving me any detail here. What's missing? So this is why we need to, it's just a small example, but hugely impactful example of why we need to overcome these vulnerability processes. I shared before the systemic racism that we have in the system. I shared before, only this slide has some more data, the systemic misogyny. I shared before that we need to work together to make this stop. So with all that in mind, I'm going to, earlier I shared paragraph 57 with you. I'm also going to show on the next slide, paragraph 56 and 57. And again, I'll let you scan and digest these. And both, I talked before about paragraph 57, so I won't labour that. But as you can see, both of these go beyond the UK law. And they go beyond the UK law because, let's face it, it's not like someone who sexually assaults a colleague, or it's not like someone who is overtly racist to a colleague didn't get the memo that these things are bad. Those terrible behaviours need to be tackled. However, as I was saying before, it's the early warning signs that this language allows us to tackle because it goes beyond the law, okay? And again, I won't labour this too much. I wasn't sure if we'd have different joiners for this section, but this is why the different interventions matter at those different times, but in particular, the golden circle ones. And I've talked a little bit in this workshop about that start for our international colleagues. So I've added some more into the golden circle there. Yeah. And that all makes a difference. And of course, and on because I'm using Mentimeter, you can see the full content here now, the bystander duty. So I want you to have all that in mind as we now watch a video, which I am really hoping the sound works. I should have tested that earlier, but let me just play that, and I'm sure the team will type into the comments if it's not working.
Davis is in bed 7. See you later, Dr. Ban.
Dr. Ban?
Yeah, they can't say my name.
What, Banerjee?
I know. Hello, Mr. Davies. My name is Dr. Banerjee. I understand that you have some pain in your tummy, so I would like to examine you and try and see what's going on.
Sorry, who did you say you were? Doctor what now?
Dr. Banerjee, I'm one of the emergency doctors.
Are you sure you're not one of the cleaners or a nurse?
No, I can assure you I am a doctor. It says here on my lanyard.
Well, you could have picked that up from anywhere. If you are really a doctor, where do you come from?
I come from Newcastle.
No, but where are you really from?
Mr. Davies, I can assure you that I'm both a doctor and that I grew up in Newcastle. Now, I am really concerned about this pain in your stomach. We need to find out what's wrong with you.
Well, I'm not sure. Is it possible for me to see another doctor?
Well, we are extremely busy at the moment, and like I said, I'm really concerned about the pain you're in. But if you'd like to tell me the reasons why you'd like to see another doctor, then that would be really helpful, and I can see what I can do.
Right, now I'm going to show you her piece to camera.
This is not the first time something like this has happened to me. It's really difficult to manage because I know I have to be respectful to patients and make sure that their care is my priority, but this kind of thing, it's hard. I know that Mr. Davies is only questioning whether I'm a doctor because of the colour of my skin, and it's really offensive when people don't believe me when I say that I come from the UK. The NHS and Trust have zero tolerance policies on racism, but it happens all the time. That's why I asked Mr. Davies to explain why he wanted to see another doctor, but sometimes I just want to challenge patients head on when they behave like this, but I'm not sure that I should. It really affects me. It's why I brush off the little things like people not being able to say my name. At least they're friendly. It still gets to me, to be honest, but it's nothing like the really horrible stuff I get. In my old hospital, one of the nurses said I always smell of curry. I mean, I don't even eat curry. And of course, patients like Mr. Davies. Anyway, another tough day and it's only 10 o'clock.
Can't tell you how cathartic it was writing the video, and the actors were so good. I was there on the day of filming to help, check for details, etc. Even though I wrote the thing, she was brilliant. It was so moving. And I've put up a vote, but as you have a look at that, one of the things that we really want to achieve with this, as you could see Dr. Banerjee there, she has no confidence that she can raise these things. She has no confidence that these things will be taken seriously. She talks about the so-called zero tolerance policy, but then what's actually happening? We need the Dr. Banerjees of this world to have confidence this will be tackled. You can't stop patients from being racist, but you can take action. And again, using these videos and other work, to be fair, that's been going on in the system for a little while now. There have been places that have not just introduced their zero tolerance policies, but they've actually introduced actions that follow, such as yellow card and red card systems against patients, ending relationships, ensuring that senior colleagues immediately have their back to someone who faces that awful behaviour. So, next question for you. And I have to say, I find it really, really interesting with some groups when I share this, or when my team shares this, they pick up on the awful overt racism. They don't always pick up on the fact that we have a colleague here who can't be bothered to get her name right because it's such a difficult name. So that brings me to my next question. What do you think? I was with 107 trainee colleagues the other night, and just under half said that the overt racism would be taken seriously in their particular placements. Only 4 thought that the microaggression would be taken seriously. Both are terrible results, you know, but wow. Yeah, I'm glad someone has said yes. And this is it. These things, as Dr. Banerjee reflected in her piece to camera, can often be dismissed as little things. They're too hard to deal with in people's minds. It's not like a colleague is trying to be evil. It's not like he needs striking off. But as I said earlier in this morning's sessions, someone needs to have that accountability to sit down with him and say, hang on a minute, it's not really appropriate, is it? How would you like it if someone said that they can't possibly say your name, doesn't have the respect for you to say that? And on a personal note, you can tell that I'm speaking, I imagine, from quite a personal angle here. On a personal note, when clients, as we call them in SARC in my other job, when there is discrimination from them, obviously I'm not saying I'm okay with it, I'm not. But if it's a colleague, I feel that a lot more it has to be said. So when we run this with organisations, as I said in this morning, we challenge them to look at their processes and the actual actions. Yeah, a policy, that's fine over here. Just like good medical practice, it gives you a lever, it's policy, if you will. It has to actually have actions to back it up. So what I'm going to do now, I'm going to show you another very short pair of clips. This time, Dr. Lee, who you saw screenshots of earlier around sexual harassment. Now, I'm going to give you a little bit of content warning. It's sexual harassment. There is no physical assault here. But nonetheless, it does bring up things for people. And I would urge you not to share things here, not because I don't care, but because I often find that when we're talking about these issues, people want to share. You feel empowered. I certainly do. And then we can sometimes regret these things. But I will signpost to support if you want to talk, because, of course, I'm more than happy to do that. But without further ado, just so that you have sight of the kind of work we're doing around misogyny.
So let's go through the jobs list.
Is Anna around? I need to speak to her about something. Ah, there she is. Our hottest new addition to general surgery.
Sorry?
Well, that dress is far more sexy than scrubs. I'd pay more attention if you'd look like that in our next audit meeting.
I need to go.
For heaven's sake. Can't you take a compliment?
And her piece to camera. It's quite interesting. The number of people in a room who said, oh, that kind of thing doesn't happen. Happens all the time. People wouldn't use language like that. Yes, they do.
He keeps doing this, and no one ever says anything. I don't know what to do. He's my consultant. At first, I tried to be nice, asking about his wife and kids. And my educational supervisor said he's a good guy, really. But, well, the other day I was alone with him, and I felt uncomfortable with him getting too close. I don't know if it's just me, but it just didn't feel right.
I'm free after work tonight, and my wife's out of town. I would like to go for a drink, and we can check over your audit.
I'm busy tonight. I need to go. It happens all the time. I don't know what to do.
Many of us will have experienced things like that. Many of us, possibly several times. And the number of times that let's say that something does escalate, and you hear, yeah, he was always a bit like that. These things are hidden secrets. And I saw in the chat earlier, the team was saying eyes and ears. These things need to be raised, but you can see Dr. Lee, she's tried to raise it. And she's been told he's a good doctor, really. I've been speaking with someone recently, and they've been subject to awful behaviours from a very senior colleague. And everyone else thinks he's a great guy because they have not experienced these behaviours from him and they can't envisage that. So, I mean, it's being dealt with now, but to just reassure you. But yes, we need to act. And I've shared the work that we're doing in this space. But one thing that I've found really, really uplifting, one area on the back of good medical practice and the new sexual safety charter, one area invited me to speak to an event that they organised, and I was really pleased to be there. And they have worked with us to develop a toolkit, so those practical actions, and it's a whole area. And they are looking at different interventions so people are comfortable to raise these things, so those early conversations do happen. Now, of course, that is what they need to do as leaders. In the meantime, until it all gets to a perfect world, which, let's face it, it's not going to happen, but I do think it's getting better because, like I said earlier, it's not going back in the box. You also need to know your roots if you don't feel comfortable in your organisation. So this, and of course the slides will be available for you later as well, gives you an overview of the routes available. Someone I spoke with recently told me that her view of the GMC changed considerably because she used our confidential helpline. Didn't feel like she could go to her organisation and found it so very incredibly helpful. So there are routes for you, whether it is freedom to speak up in your own organisation or confidential helplines or allies. So as I wrap up, we are encouraging those leaders to use good medical practice as a lever. We have seen organisations use good medical practice as a business case to bring in that bystander work, that proper bystander work, have ongoing conversations, etc. HR teams are launching things like inclusive HR. Cheryl Samuels, some of you may have seen, does great work in this space. So there's lots of good news. I've shown you some shocking things. We've talked about difficult things. But I think these things have to be talked about because we spent too long not doing so. And that's why we have the problems we do. Good news is that these interventions work and some places are implementing them. There are challenges. We have, as I say, no regulatory remit, for example, over HR. For example, around making organisations embed differential attainment interventions. But we are working with them to influence them. And that, as I say, is having an impact. There is a lot of misinformation out there, and that's why I again encourage you to raise awareness of the work in this space, use your networks, and as someone said earlier, we will really be delighted to come and support you in your organisations. And that brings me really to the penultimate slide, the final one's just a thank you. Please use us in outreach. We're having these conversations everywhere. But if your organisation would benefit from this, then please do invite us. Thank you very much. I've been keeping an eye on the comments and there haven't been any recent questions, but I'm around. So if anything does strike you, then I'll be around to answer it. Thank you very much for your time. And I hope that was helpful.